Thank you, Dr. Stifelman, and welcome everyone. Thank you all for joining us tonight. My topic today is going to be about urinary tract infections, which from the surface may not seem like something that is interesting, but I know that many of you that are listening here suffer from this problem, and many of my patients and many women across the country suffer from this problem. So I hope to enlighten you on urinary tract infections, how they happen, why they happen, and the trends and research that we at HMH have been invested in. So let's get started. So as I said, this is a common problem, not only amongst my patients, but across the country. 150 million people per year suffer from urinary tract infections, and it's the most frequent bacterial infection in women, affecting just about half of women at some point in their lives. That's 1 out of every 2 people. And not only that, but it's not just one infection. Half of these people develop a recurrence of their urinary tract infections within 1 year. This problem accounts for 7 million office visits, 1 million emergency room visits, and 100,000 hospitalizations per year for a cost to this country of over $2 billion. So why is this a problem? You have an infection, you take an antibiotic, the problem gets better, right? But there's a problem. And the problem with antibiotics is, although they may take away the symptoms of a urinary tract infection fairly quickly for you, whenever we give an antibiotic, the bacteria that cause the infections can be smart, and they can outwit the antibiotic, and they can become resistant to that antibiotic, meaning that antibiotic will not work. And this is a problem because if you take a lot of antibiotics, you're going to get a lot of resistance. And when I say antibiotics, it could be for anything. It could be a Z-Pak. It could be an antibiotic for a skin infection or an antibiotic that you took after a surgery. Antibiotics are used rampantly in this country by physicians and by patients. And when we do that, we create resistance. And when we get resistance, we have problems because then we may run out of options to treat infections. So, as I said, antibiotic usage is the primary reason why resistance forms. But there's also the food that we eat. In livestock, livestock are treated with antibiotics. We eat those livestock. Those antibiotics can potentially be transmitted to us. And there are lots of people that are treated with antibiotics for no real good reason. So some people can have bacteria in their urine, for example, but feel fine. It is known by urologists and infectious disease specialists that these kinds of bacteria should not necessarily be treated. But yet there is often overtreatment by lots of physicians of bacteria in the urine that need not be treated. So this incorrect usage of antibiotics plus the ingestion of antibiotic-treated livestock can lead to bacterial resistance. The reality is, most symptomatic urinary tract infections can be treated with a short course of antibiotics, so it's not like we should never give people antibiotics, but we have to be very careful about how we use antibiotics. So when I looked at my patient population between 2015 and 2016, we're looking at 908 patients with urinary tract infections, over 2,000 positive cultures. And about a third of these patients had 3 or more urinary tract infections during that study period. And the most common organism was E. coli, and this is the most common organism, and it's well known amongst people who have urinary tract infections. But when we looked at resistance, we saw some not surprising things, but here you see on the bottom here, you can see the most common antibiotics that we use. Fluoroquinolones, you guys may know this as Cipro or Levaquin. Okay, TMP SMX is a fancy word for Bactrim or a sulfa drug. Cefazolin is also called Keflex. These are 3 of the most common oral antibiotics that we use for urinary tract infections. And if you look at these cultures, more than 1/3 of them were resistant to fluoroquinolones and sulfa drugs. And when we looked at how many of these organisms were resistant to 3 or more oral antibiotics, it was as high as 30%. Let me tell you, there aren't a ton of oral antibiotics out there. So if your urinary tract infection fell into this category, you could be in trouble in terms of not having a proper oral antibiotic to treat you. And then what do? Well, then sometimes we have to give intravenous antibiotics, which is a much bigger deal. So then we started looking at our patients from 2019. So those were patients in 2015 to 2016. In 2019, we had 334 patients with 704 positive cultures. And what we found is that the patients who had recurrent urinary tract infections were different than the patients who had sporadic urinary tract infections. So sporadic urinary tract infections are once in a blue moon. The recurrent urinary tract patients, those are people who have 2 or more infections in 6 months or 3 or more in 1 year. What we found was almost half of our patients have recurrent urinary tract infections. And the patients with recurrent urinary tract infections were older and had more resistant organisms. And again, this is not surprising. The people who get recurrent urinary tract infections, they're getting more antibiotics. Their bugs are going to be more resistant. And in this population of patients, when we looked at specifically E. coli, the rates of resistance to sulfur drug, which again is one of the most common drugs that we use, went from 34% in 2015 to 43% in 2019. So we're creeping up. Resistance is getting worse. Why? We think because of inappropriate overuse of antibiotics. So what do we do about this resistance? How are we going to reduce resistance? Okay, so I started looking at this by looking at our own practice, okay, and looking at urologists and what we're doing in terms of inappropriate usage of antibiotics. And historically, urologists have given antibiotics out a little bit like candy after urologic office procedures like cystoscopy, urodynamics, and things that we do in the office. And so what I did was I looked at our patients in our office who we were not really giving these antibiotics to people. In my practice, I was limiting this and really only giving it to very few patients after urologic procedures. So we had 250 patients in 2017 and 2018 who underwent simple office-based procedures without antibiotics. Only 12 of them, only 12 of 250, that's 4.8%, developed a symptomatic urinary tract infection. No patient developed a serious infection, and no one required a hospital admission. So then, okay, that's one of the things that we can do to reduce resistance. But one of the other things that we need to figure out is where does this bacteria come from? And how can we address it, understanding where the bacteria comes from? We've always thought that the bacteria comes from your own flora. So, for example, in the vagina and in the rectal area, the perineal area, there are bacteria that normally live there. And what we think happens is that those bacteria get into the wrong place. They migrate up into the urethra and they create an infection in the urinary tract where it doesn't belong. And so what we're doing, because this has never been proven, is we are going to prove this. And this is a study that we're working on with the Center for Discovery and Innovation to identify a reservoir for these infections. Are they in the vagina? Are they in the bowel? And we are going to figure that out. The other thing that we are working on doing is partnering with a company that makes bacteriophages. What is a bacteriophage? It is a virus, but it's not a bad virus. It's a good virus. This is a virus that is designed to kill a bacteria. And what we can do is we can engineer a virus to kill the bacteria that causes urinary tract infection. And it can be catered to the patient's infection. And this is groundbreaking research that we are about to embark on, that we look forward to, that could really be a game changer across the world for the management of recurrent urinary tract infections. So the bottom line, what we want to do in our research is try to identify ways to minimize antibiotic usage in the urologic community and in the medical community at large. We want to reduce resistance, and we want to identify novel agents for the treatment of urinary tract infections. Thank you all for joining tonight. I look forward to answering your questions.